we will move forward towards our next session. And to chair the session, I request Professor Rakesh Chadda, who is Professor and Head of Department of Psychiatry and Chief of NDDTC at AIIMS Delhi. And Sir needs no introduction. He has extensive work in consultation license psychiatry, social psychiatry, and addiction psychiatry. And he has been Secretary General of World Association of Social Psychiatry, and he is Fellow of World Association of Social Psychiatry. And he is ex-president of IASP and Life Fellow of IPS, IASP, and IPM. So I request Chadda sir to take forward the proceedings of this session. Please.
Thank you, Dr. Mukesh. It gives me great pleasure to be here in this CME on recent advances in addiction psychiatry, and especially with the session of Dr. Debashish Basu, who is an old friend for more than almost 35 years. Dr. Debashish Basu, as we all know, he's a professor and head Department of Psychiatry, Postgraduate Institute of Medical Education and Research at Chandigarh. His areas of interest include addiction psychiatry, dual diagnosis, social psychiatry. He has been, he's also currently the, in fact, he's the founder editor of World Social Psychiatry, which is not mentioned here in his achievement and special contributions. And he has a number of awards to his credit, and is an excellent speaker. I won't be with taking more time on his detailed introduction, because that would be take time of his presentation. Dr. Basu will be speaking on tele addiction psychiatry. This is one area which has emerged, especially in the last 2.5 years, in the background of, or I would say it's a gift of COVID pandemic. His topic is whether this tele addiction psychiatry is only for COVID times or here to stay. I'll request Dr. Debashish Basu to take over.
Thank you. Thank you very much, Dr. Chadda. And it's always a pleasure to be here. So let me just first start. Yeah, okay. So dear friends, good afternoon, good morning, and good evening, depending upon where you are at the moment. I'm going to present after the two very important talks preceding mine, both of them of different nature, but extremely important. This is covering another area of the recent advances, not so recent really, but as Dr. Chadda said, it's really burst into the scene since the COVID had come. But the question is it only for the COVID times, or is it here to stay? Of course, we are talking about tele-addiction psychiatry. So without any further ado, and I'm assuming that the audience would be knowledgeable about the basics of telemedicine. So we won't spend time on that. Otherwise, there's a lot of ground to cover later. So as we know that the essential feature is a tele word. The operative word is tele, which is from a distance or across a distance by using technology. And telepsychiatry is when that's applied to mental health care, and tele-addiction psychiatry when that's applied to addiction psychiatry or addiction management. The context, again, as we all know, I mean, this need-supply mismatch has been a constant feature of addiction psychiatry services. It has always been there, and studies after studies from everywhere in the world, including our Indian national studies, of which Dr. Ravindra Rao and Dr. Ambekar were the main authors, they have shown repeatedly that there's a huge treatment gap. But what the COVID-19 pandemic has done is that it has accentuated, it has really unmasked, accentuated, and then shown the chinks in our armor, never seen before to that extent. Because on one hand, there's been an increased need for various reasons, And there's been, at the same time, there's been a decreased supply of the services, again, because of the lockdown and related difficulty in accessing treatment, healthcare, and very importantly, the social determinants or the structural determinants of care, starting from the vulnerable groups, the marginalized groups, the poor, the other things, they usually always get the worst lot, but COVID-19 extremely accentuated and unmasked these differences as well. So all in all, as it has been mentioned elsewhere, that it's been an epidemic within a pandemic. In this context, big associations like the American Medical Association has actually hailed telehealth as a lifeline for patients with substance use disorders of late. And we are all aware of the major pluses, which are quite sure, all the 5 A's of public health or community medicine, which will be applicable for telemedicine or tele-addiction psychiatry: availability, accessibility, very importantly, affordability. When you combine the fact that you don't lose time and money going, and when especially transport is not there or is very costly. Acceptability, there would be a plus minus about that. We'll come back to it later. Acceptability and appropriateness. Again, a little bit of question, my plus minus there, but we'll come back to that later. But these are the 5 big A's of community medicine, as we know, and kind of telemedicine tends to check all the boxes. Particularly for SUD, for substance use disorders, telemedicine can be more useful because it is less stigmatizing and more flexible. However, having said that, there are major minuses along with these obvious pluses as well. So I'll try to give a balanced presentation. I'm not trying to tilt the audience this side or that side. The biggest problem which has been noted with telemedicine or with any technology-based treatment healthcare is the quote-unquote what's called as a digital divide. The divide between the haves and the have-nots, the marginalized in the other group. When people, particularly in low and middle-income countries, in low-income countries, when there are no mobile devices, when there are hardly any electronic notepads or devices, when there is only one per household, which is there with the main income earner of the family, and the person cannot access that. There are hundreds of examples of the digital divide, which makes it inequitable in the access to the management. There are patient factors which include privacy concerns because of the setting where you're sitting and doing, and expectancy from in-person visits. People are often interested in seeing their doctors, in talking to them, in having that touch, quote unquote, rather than so. And then there are clinician or health provider factors, something known as performance expectancy. What is our own biases, attitudes or biases, conscious, less conscious, whatever, about how this tele thing is likely to perform. So there are many expectancy biases, of which performance expectancy is a main one. And then, of course, there are big, huge administrative or logistic factors, of which one of the most major ones, which we are aware of, is a restriction on prescribing many medications for substance use disorder treatment. Things like buprenorphine cannot be prescribed under the Indian telemedicine gazetted notification. So we cannot do that. And that's just one example. We can't even prescribe lorazepam or chlordiazepoxide, etc. We'll come to that. So these are the administrative, and then there are, of course, financial policy factors. So it's a kind of a mixed bag. But accessibility of treatment by telemedicine tends to trump everything else. This article was published before the pandemic, which showed the current practices and the organizational characteristics. It showed that these were the 10 or 11 major technology which are there for the various kind of modalities. So we'll spend 1 or 2 slides on some of these, the main ones, like the computerized assessments, texting, web portal, mobile apps, video based, and now everything is video conferencing, as we know, is video conferencing, telephone-based support, various kinds of telephony or audio-based support, etc., etc. And then ending up in things like virtual worlds or avatar therapy or virtual reality or AVR and all those kind of things. What interestingly they found is that these authors did a latent class analysis of the organizational characteristics, and they identified 3 latent classes. This is interesting. One they called as innovators. So there were certain organizations which were using a range of these innovative technologies, and they were willing to experiment. They're willing to play around, try this and try something new, etc. On the other hand, there were organizations which were technology traditionalists that limited their use to traditional modes, telephone, video, and web portal technologies, but would not like to play around with newer things or with mix and match kind of a thing. And finally, a large proportion, if you see the highest proportion of the organizations, nearly two-thirds of them were quote unquote low tech. So they were happy with the low overall technology use, and they say that we are fine, we're doing just fine. We don't want video conferencing and stuff like that. So this was the characteristics which can be useful, which can be important in this area. Now, this Mayo Clinic article I found it extremely useful, a very good article which talks about in the COVID-19 pandemic era. So I gratefully acknowledge that some of these slides, these are taken from that article with the acknowledgement. So they've talked about simple best provider practices for telehealth visits, things that we are well aware of. Establish a professional looking office space, reliable internet connection, positioning of the internet, the basics. Try to maintain a positive attitude, ensure a private setting, etc., and a backup if the internet is unstable or that device is unstable. I won't go through this, but these are the basics of the conducting an addiction-focused telehealth visit. Essentially the same as an in-person visit, but so you go through the complete history, try to establish the diagnosis, look for visual signs to the extent possible on the Zoom or on the Skype or FaceTime or the video, signs of intoxication or withdrawal. At least evaluate for suicidal thoughts or current depression, because that would be important for an emergency management, etc. So after an assessment, after establishing the diagnosis, that's what we do. You start prescribing some of the medications within the policy regulations of the country or the state where we are working, and subsequent visit can be scheduled. This is something which we don't have. In India, we don't have. But in USA, during the COVID-19, the authorities, as we all know, they made this what's called the emergency use authorization, or rather emergency waiver, and they say that you can actually start the induction of buprenorphine at home, which we can't do. For us, patient has to come in person. But this is the details. There are further details available. So one can actually carefully, slowly start the buprenorphine home induction as well. These are some of the relatively common tele-addiction modalities or telemedicine modalities used to substance use disorder. One is the commonest one of the easiest relatively ones are the computerized or the web-based assessments and treatments with no live interaction. In other words, what's known as asynchronous or store and forward technology. So patients can access them later anytime. The advantage is that they can be useful later as well, and not just during the live moments. And common elements being things like screening assessments like the audit, the cognitive behavior therapy modules, some of them motivational therapy sessions, psychoeducation, behavioral skill building, links to various kind of recovery or self-help groups, and computerized brief interventions. All these are possible at the patient's own leisure time and the flexibility of his or her time and convenience. The majority of studies actually show the positive effects of these tools in addiction treatment when they focus on the electronic delivery of evidence-based strategies. However, quality is very important. On the other hand, Telephone-based recovery supports and telephone-based telehealth modalities are synchronous usually. So you're talking about something which requires real-time contact between the patient and the clinician, which offers phone calls for support, link the patients to other resources, and deliver brief interventions. These are minimally resource intensive because you just need the phone. And that, apart from the capacity to deliver effective brief intervention, there is hardly any cost of infrastructure. Current evidence only supports the use of telephone-based telemedicine in continuing care after completion of traditional addiction treatment. And it may be related, more data is about alcohol use disorder rather than anything else. On the other hand, by far the commonest use now, by far, is synchronous. What we have been doing day in, day out is during the pandemic at least, there is the synchronous video conferencing, because smartphones and tablets, and especially, they have become ubiquitous over the past decade. And studies have repeatedly shown that compared with in-person treatment, video conferencing for similar modality treatment of SUDs is at least no less effective. It may not be more effective, but it's usually not less effective, and is associated with significant patient satisfaction and safety. And especially with alcohol use disorder, it's associated with reduced dropout, reduced consumption, higher abstinence rates, and higher satisfaction. With opioid use disorder, it's a slightly more mixed bag, but still there is reasonable some evidence in its favor. Text messages are one of the simplest ones. Simple telephone text messages. We have been using this. It is most often used, of course, as reminders, as appointment reminders. Text messaging has been shown to decrease the no-shows. Okay, so that's one thing, that's commonest one. But texting interventions can also include things like craving helplines, automated CBT, relapse prevention skill support, personalized messages delivery based on stage of change, for example, and personalized motivational reminders. When used for smoking cessation, there is a reasonably good evidence that it has shown improved long-term abstinence rates in 11 randomized controlled trials with nearly 13,000 combined participants. As such, it's a simple, very simple and cost-effective tool, text messaging. However, as you will see, usually the providers or even the patients, they don't like it. They like video. Come to that. Smartphone apps, this is the era, the zamana of apps now. So there are literally hundreds of them, or maybe thousands, who knows. They represent a nearly continuous opportunity in a virtual addiction treatment, and it's a rapidly emerging market attracting the attention of everybody. Everything is possible, probably. Everybody tends to be devising some kind of apps, including our own center at the moment. And you can have things like personalized notifications, direct connections to support persons, in vivo assessments, real-time interventions for cravings, contingency management-based e-rewards, and global, even GPS-based e-tracking, alerting the patient when they approach a high-risk location. So virtually there is no end to it, and it's still. Last but not the least is this new thing called, the exciting thing called virtual reality, or augmented virtual reality, or things like that. Both asynchronous virtual environments or synchronous virtual worlds, where you can have your own avatars, your own digital avatars, to interact in real time with peers and clinicians. Sounds fun, looks fun, but still there's not a lot of evidence about that, and it can cost. It can burn a huge pocket, a hole in your pocket. Medication-assisted treatment, particularly for opioid use disorders, something which Dr. Shalini was referring to earlier, is there. People have been using it. It can't be used, obviously, for long-acting injections because you cannot dispense it. But even there, or for other purposes, it can be used for assessment, establishing a diagnosis, establishing support systems, establishing links, and making a plan. All these things can definitely be done to supplement the medication-assisted treatment of opioid use disorders. However, all are not the same. Some patients may benefit tremendously by coming to the clinic, in person, meeting with the counseling staff, sharing experiences with the other patients in treatments, taking medication-assisted treatments, giving a urine test, etc., etc. Whereas other patients may appreciate the convenience of virtual options. So what matters to the patient? Patient satisfaction, particularly for medications for opioid use disorder treatment, because that's one of those kind of contentious issues. In a very recent literature review, they found that there are 4 or 5 elements which matter. One is the communication. To what extent is the information being exchanged? How effectively? The privacy matters. Patient perception of the acceptance of the telemedicine medium, the patient's own expectancy aspects, utilization of the technology. Some people may not be very good with the buttons and with the things, etc., especially with people who are of a different, marginalized sections. And finally, treatments of access or various barriers to treatment. So depending upon that, satisfaction will be there. But despite these factors, again, these are all recent articles, very recent articles of the last one year or 2 years. So patient perceptions, good studies. This one is from Harvard and from McLean Hospital, and then they found that for individual therapy, there's a very high satisfaction. The top row, very high satisfaction for individual therapy. But for group therapy, the satisfaction level goes down. That's the middle row. You can see that the deep colored selection is much less. So satisfaction is low. And for medication management, it's somewhere in between. So it varies. But for individual outpatient therapy, there's a good level of satisfaction. So there was overall high satisfaction, very high, with telehealth services. And many participants found telehealth was more accessible than in-person treatment. However, there was a variability, particularly in respect to group therapy. Same thing that we found, we could not do very good group therapy in the tele mode. We have been trying, but it's not really that good. There are problems. So, difficulty forming connections, etc. That was what matters to the patients. And now what matters to the clinicians? This is interesting because normally, well, it's a mixed bag again. There are many studies which have shown that clinicians are actually quite happy. But this particular study from Canada, again, quite recent. These are all very recent studies, large ones, good studies. They said that clinicians actually reported more positive experiences with in-person services than both virtual means video and audio technologies virtually. And within the virtual technologies, they preferred video services than audio services. And as I said, that performance expectancy that positively predicted whether they want to further use video technology or audio technology, that is telehealth, after the pandemic or not. So that's an interesting point. So how does it compare with in-person? The big question is, how does it compare with in-person for addiction management? Again, studies after studies, not too many, not compared to the general telepsychiatry, of course, but there are a few, and we have some reviews of various kind of studies. Not many, as you can see, there are 7 published studies, so some of them found better retention, etc. Because of the shortage of time, I'm not going into this, but if you can see that the less effective, the deep black bar, the less effective is for group counseling and for intensive outpatient treatment. Okay, so it's not that's not a very good choice. It's not a very good choice for that. On the and this very influential 2019 systematic review, which focused only on which focused on nicotine, alcohol, and opioid use, it found wide variation in methodology, in size of the studies. Many of them were low-powered, quality, etc. However, when taken together, they found that there was high patient satisfaction and is an effective alternative, especially when we run out of other alternatives. However, they noted substantial methodological limitations to the research. This is the latest one. This is the latest one published, I think, last month, and the largest one, published in Annals of Internal Medicine. And this took only randomized controlled trials. It's only DSM-5 or methodologically superior studies were chosen, and quite recent ones, only the last about 6-7 years, with a reasonable follow-up. So this was a methodologically superior systematic thing, where they found 17 RCTs fulfill their criteria for multiple various substances. Unfortunately, the major conclusion that they drew was that evidence was very uncertain. They have not said evidence is poor, that it does not work. It says there's uncertainty of evidence that video conference therapy and web-based CBT have similar effects to in-person care on abstinence and substance use outcomes. However, limited evidence suggested that when added with standard care, so it's as an add-on, as an adjunct therapy, some telehealth technologies, especially telephone, simple things. The simplest one was the winner. Enhanced telephone monitoring, telephone monitoring by various texting and telephone things may improve abstinence and readmission to inpatient care compared with standard care alone. So based on this, the NIAAA of USA, in their newsletter, they said that the jury is still out. Their bottom line was, this was based on this LINS review. But later on, the latest one which has come up, this actually again shows, and this is a very large one. This is based on the Betty Ford Foundation study all over the USA. I'm not going to the details, but essentially what they showed, very interesting, and they took all these scales, various scales, followed up to 12 months. And what they show is, interestingly, is that individuals who participate in hybrid programming, where both the elements of in-person and tele is judiciously mixed, they are the ones who stayed in treatment significantly longer and were discharged against staff advice, LAMA as we call it, at a lower rate than those. So they fared better than either in-person, the traditional ones, or internet-based only programming. Question is why? I'll leave you to think about it. I won't, because they have not given answer, but they've thought of. Based on this now, NIAAA, in its latest newsletter, they have changed it. And they actually now says that pandemic underscores the needs for and benefits of telehealth. So we are kind of, what I'm trying to say is that we are kind of there, but not quite there. Which is preferred, video or audio? I think we have already given the answer in a previous study. And this one again, quite a recent study, has again a very large ones, 457 organizations were surveyed in the entire USA, and the odds were better for video technology to telephone technologies for virtually all the services. So where do we go from here? Post-pandemic, that was a point. Do we still want this? There are many articles, so I'm just going to brush through them because of the time. Primarily, the question is that, is this a lasting change? COVID-19 pandemic thrust upon us this open thing. This opened up this box. But question is that, is it going to last? Or if it's going to last, how should we do it? A more important question is that, right? So some of them actually found that there is now a partial rollback of some services to a pre-pandemic model of care, creating a seemingly hybrid service provision system. As they say, our data indicate that there seems to be a clear preference for the pre-pandemic model of care with face-to-face appointments, which does not augur very well for telehealth's a future. However, people have talked about how to use telehealth. After all, it has its great advantages about particularly accessibility, affordability, and all those A's. So these are many of the structural points. I'm not going to great details now, but we can talk about it later if time permits. Service-related changes, staff-related changes. You have to engage staff. You have to outreach to the patients, etc. So people have been talking about this. The latest Psychiatry Clinics of North America, which is talking about how to and for whom we need more in-person treatments. And everybody's talking about, if you see the point number 3 there, the bullet number 3, it says very clearly that in-person and remote care, telecare, for the treatment of SUDs are complementary. And a hybrid model of care that includes combination of both is likely to meet the needs of those seeking care. The question now arises, which is the right combination for whom? What works for whom with telemental health? Studies after studies, this is from preprints from the NIHR UK. They found that these are the domains which are very important: connecting effectively, keeping a degree of flexibility and personalization in the services, not making it too rigid, enforcing the areas of safety, privacy, confidentiality, and not compromising therapeutic quality and relationship. So I think I'm going to rush over that. SAMHSA has this very nice toolkit for guidance to support high quality care, particularly for buprenorphine. So that may be very useful. It's a very useful story. So there are various kind of changes which have been advocated. Last 2 minutes before we finish, I cannot not talk about India. So I hope the chairperson will. I know I'm running late, but just 2 minutes about India. Nuggets of history was started by the Schizophrenia Research Foundation following the tsunami of 2006, and which was followed with extended to the STEP model for chronic schizophrenia patients using a mobile bus there that time. PGIMER Chandigarh started its own Tele solution, a software based with data consultancy services called Psychiatry on web, a much more detailed solution. And AIIMS Bangalore were the first one to use their hub and spokes model for addiction psychiatry, where they trained primary healthcare workers. Based on this multicentric survey, which has been just published in the Indian Journal, as you know, that there is it was very difficult to get access to treatment during the COVID-19 for treatment, for medication, and for opioid agonist therapy all over India, or at least for all these multi-centers which participated in this study, including AIIMS Jodhpur. AIIMS developed this model called, faced with the COVID-19, a model called eConsult. eConsult is essentially the model in which there are already trained healthcare providers in the periphery, in the primary healthcare. They write a eConsult form, send it by mobile or email, and get back the response from AIIMS about how to do about it. That is e-consultation. And they found that it was well accepted. It was the providers, the doctors, they were happy in the peripheral. On the other hand, we developed in PGI, Dr. Abhishek Ghosh is a primary thing. I think he's there in the audience also. He and the team developed this thing called the stepwise model, or the telemedicine, which is a 3-step model, starting from initial a telephone call, followed by a video conference if needed, as and when needed, and followed by in-person as and when needed. I'm not in the details of that, but we have compared the two. They are very different models. One is synchronous, the other is asynchronous. Requirements are different, but we feel that the ideal telemedicine-based care could combine elements of both the models. And that I'll finish off with this rather sad and disappointing figure from our DDTC data. As you can see, that the red ones are April to August. That was the time of the second wave, the Delta wave, the worst wave of thing. You can see, because the OPD was not working at all practically. So virtually the walk-in clinic data, the walk-in clinic, in person, very few numbers. Tele, much higher numbers. However, from October onwards, as the things got stabilized, the numbers have just become almost opposite. And now the tele numbers have gone down, and in-person walk-in clinic visits have increased significantly. Same about follow-up visits, also numbers are much higher, but the pattern you can see is pretty much same, that especially now progressively the tele numbers are decreasing and the in-person follow-ups are increasing. So this is important to understand, that if we have to continue the tele, we must learn our lessons. On the other hand, the DDTC teletherapy data, we have started from last year a teletherapy, telecounseling. There the numbers are not high, but they are more or less the fixed numbers. This Gazette notification of telemedicine in India, which has been talked about, it does not allow the prescribers to prescribe benzodiazepines, buprenorphine, methadone, or even tramadol In fact, as a modification, it only allows clonazepam, clobazam, and phenobarbital. So it severely restricts the addiction psychiatry as far as telemedicine is concerned. And a recent draft is also there, which the Addiction Psychiatry Society of India has written to the NMC, the National Medical Commission, for reconsidering this complete prohibition and to change it. So in conclusion, emerging evidence, it does support acceptability by the patients. Okay, but it's not. The main point is that it should not be receded post-pandemic, and there's a pressing need for evaluation and participation. We need to know what works, for whom, how we can make it better, and that is the important thing. In the end, tele-addiction psychiatry is a valuable tool that can improve access to care, including for those who are constrained by circumstances, and perhaps quality of care as well. But it is a tool to be used intelligently. It is not a panacea. Thank you. Thank you. Sorry for taking longer than what I thought. Sorry. Thank you.
Thank you, Dr. Basu, for a very comprehensive lecture, though you exceeded the time. Yeah. And you have very well covered pros and cons of addiction psychiatry or telemedicine in addiction psychiatry. And definitely there are many limitations of using telemedicine and addiction psychiatry, because we can't dispense a narcotic group of drugs, and we can't prescribe those drugs, and there are a lot of issues in getting these drugs outside. So that remains one biggest limitation, but definitely in engagement and in non-pharmacological interventions and tracking the person, tracking the appointment, improving adherence, there are issues where definitely the medicine approach is of great value. We have one interesting question, though you have partly covered. Dr. Alok Agarwal asking the kind of medication that can be prescribed online based on operational guidelines limit tele-addiction psychiatry. Your comments. Would you like to comment? So you have.
No, I think, thank you very much. I think I've already commented on that. I said that it does severely restrict, and we would very much like the situation to change. I think all of us are in this together, and it does need to be changed. I entirely agree.
Another thing, since there are not many questions, in fact, there are more comments, not questions. Highly stimulating and informative, as usual, presentation by Dr. Basu. So, from one of your students, Yogendra Malik.
Yeah, I don't know what the last line there means. Your voice, sir, is really killing. Is it that bad?
That you can ask privately.
Okay. Thank you. Thank you.
So, at AIIMS, we have used telemedicine in more in training of the doctors, where Dr. Ravindra Rao also developed a module and a flexible module, and he has been conducting those courses for last almost 1 year and giving a kind of diploma certificate. So that's one area where telemedicine has also got utility, or say that's somewhat parallel. And like the ECO program, the NIMHANS, what you said, that's providing secondary consultation to the primary care doctors. So that's one area where it has got great value, because there you can guide the primary prescriber, and that person can prescribe the medication. So I think all of you have enjoyed the lecture. Anyone if wants to put question, because there are not many questions, there are more comments. They don't invite any response from the speaker. Any last words, Dr. Basu?
No, sir, I think that's all, and we will be very happy to take it, because we are running late for the next speaker who is waiting. But I thoroughly enjoyed this. I wish we could have more time to discuss. There are other subtleties and nitty-gritties, nuances in all these things, but that calls more for a workshop like pattern rather than, along with my dear friend Abhishek and other people who are working in this, rather than this kind of a lecture. So I think I'll stop here and thanks to everybody. Thank you so much.
Thank you, Dr. Basu. So I conclude this session and I thank Dr. Basu as well as all the audience for interacting and be here. Thank you. And I thank the organizers. Thank you.
Thank you, Will. Thank you for excellent presentation.